Hello, and welcome to our course, Eating Disorders: An Overview for Clinicians. I'm Dr. Evelyn Attia, Professor of Psychiatry at Weill Cornell Medical College, and I will be joined shortly by my colleague, Dr. Matthew Scheer, Assistant Professor of Psychiatry, also at Cornell. Today we will be discussing the eating disorders, actually the feeding and eating disorders that are described in DSM-5. They include anorexia nervosa, bulimia nervosa, binge eating disorder, also nicknamed or acronymed BED, avoidant restrictive food intake disorder, or ARFID, pica, and rumination disorder. I'm going to begin with the DSM-5 diagnosis, anorexia nervosa. This isn't very different from the way that anorexia nervosa has been described in the prior DSM manuals. Actually, it's not so different from the way anorexia nervosa has been described for centuries. But at present, we've got three diagnostic criteria, and they include restriction of energy intake, or real restricted food intake relative to one's requirements, leading to significantly low body weight in the context of a person's age, sex, developmental trajectory, and physical health. We're not defining significantly low weight in any one particular way, but it's a weight that's minimally normal, or for children or adolescents, a weight that's less than what's expected for their age and their prior growth history. Also, an intense fear of gaining weight or becoming fat, or persistent behavior, maybe something that's observed by others that interferes with weight gain, even though the individual is at a significantly low weight. Lastly, we've got a disturbance in the way one's body weight or shape is experienced, an undue influence of body weight or shape on self-evaluation, or a persistent lack of recognition of the seriousness of the current low weight. If those three criteria are present, one meets for anorexia nervosa. There are two subtypes of the disorder, the binge eating or purging type, or the restricting type, and really those just indicate that there's a consistent pattern over the previous 3 months of just the restricting behaviors leading to the low weight, or a combination of behaviors, some of which may include binge eating or purging. Anorexia nervosa is actually quite rare in the general adult population. The lifetime prevalence for the illness is 1 to 2%, and we see new cases about 5 per 100,000 people per year. It's a far more prevalent condition among adolescents. In one study, 270 among 100,000 adolescents per year, aged 15 to 19, are affected with the disorder. And with the DSM-5 criteria that are a little bit broader, a little bit easier to use among individuals who are just starting out with this condition, we do expect slightly higher numbers than some of what's been described using prior manuals. This is an illness that's more prevalent in females than males, with about a 9-to-1 ratio in clinical groups. It turns out that this is an illness that seems more prevalent in healthcare settings. Among a large group, 942 adolescents who presented to an emergency room for a whole host of medical reasons, about 16% of people screened positive for an eating disorder, many of whom, especially among the adolescents, screened positive for anorexia nervosa. Anorexia nervosa is a serious illness. The rates of illness or morbidity for this condition are really quite high, with just about every organ system being potentially affected by anorexia nervosa in someone who's really had the condition for a while. In the cardiovascular category, we see slow heart rate or bradycardia. We see hypotension or low blood pressure. We may see low temperature, hypothermia. We'll see some arrhythmias on electrocardiogram, including prolongation of the QT interval or QT disturbances. We may see peripheral edema, and really as someone begins to refeed, if they are in some refeeding crisis or refeeding syndrome, we may even see a more profound problem with fluid accumulation, including the possibility of infiltrates in the lungs and really fluid just about everywhere we look. Hematologically, we see low blood counts, with the white blood cell count being the most commonly affected, leukopenia, but we may also see anemia or low platelet counts, thrombocytopenia. In the gastrointestinal category, we may see slow GI motility with decreased stomach emptying. We may see abnormal liver function tests as the liver enzymes could be elevated in this population. We quite rarely, but sometimes and concernedly, may see renal function difficulties. And in terms of endocrine abnormalities, there are a number of hormonal changes that we see in the semi-starved state associated with anorexia nervosa, with low estrogen, low LH and FSH, low testosterone in males, all possible in the context of anorexia nervosa. I mentioned one other endocrine problem specifically because it's the one medical complication where we sometimes don't see a resolution of these symptoms when someone has been treated for their anorexia nervosa, and that problem is osteoporosis. Bone mineral density can quickly become a problem with osteopenia or osteoporosis possible with as little as a year of illness in some individuals. And while we hope that someone has gotten treatment quickly enough that we can see some improvement in bone metabolism, sometimes these problems do not correct with weight restoration. In terms of the skin, we may see dry skin, brittle nails, thinning hair, and a pattern called lanugo, which is that of fine hair pattern in the underweight that we commonly see in babies but aren't supposed to see in healthy adults, but we do sometimes in the low-weight anorexia nervosa patient. And in terms of neurologic systems, we may see a decreased brain mass on a brain scan, and a number of psychological symptoms that actually we know to develop or worsen in the context of low weight. Here's a picture of a young woman with lanugo, that fine hair pattern that I mentioned, which appears on her face and on her neck. This is a pattern that we would expect to resolve with refeeding. Anorexia treatment is quite a challenge for those of us in the field. Many treatments are modestly useful and allow some restoration of weight and nutritional status, but there are no specific psychotherapies with robust empirical support. Weight gain, we know, is an essential first step, and a substantial amount of kilocalories and consistent support and supervision are often needed to achieve this. Essentially, individuals need a full 3,500 calories above their maintenance requirements in order to gain 1 single pound, and many of our patients are presenting to us with many pounds of weight restoration necessary to reapproach a normal weight range. Sometimes outpatient settings can be used for these treatments, but sometimes more structured settings, such as day treatment programs or hospital settings, are necessary to help individuals achieve this change. Surprisingly, medications are of limited value. Medications that may work in lots of other clinical populations for the treatment of mood or anxiety symptoms don't seem to work in the same fashion when someone is underweight and struggling with anorexia nervosa. The only exception may be some preliminary data that are suggesting that the atypical antipsychotic medications, and specifically olanzapine, may be of assistance as part of a treatment for anorexia nervosa. What happens in terms of the treatment? What happens to individuals who've been affected with anorexia nervosa? Many of them recover and recover fully, and we routinely see in samples a third to a half of individuals who may present for high levels of care for this disorder recover fully a number of years after that initial presentation. Nevertheless, this is a serious illness with very high mortality rates, and we actually see the rate of death as 5% per decade of illness. These are significant mortality rates associated with this condition. Of note, some of the mortality associated with anorexia nervosa is due to cardiac effects and other difficulties that are secondary to the state of starvation, but almost half of the deaths described in this group may be due to suicide. We know that treatment at a younger age leads to better outcomes, and early intervention is always preferred.
My name is Dr. Matthew Shear, and I'm going to start by discussing some of the DSM-5 criteria for bulimia nervosa. The first criteria is recurrent episodes of binge eating. We will go into more detail about what a binge is, but it's often described as a discrete period of excessive food intake, where patients often have a lack of control over their eating. This is followed by recurrent compensatory behaviors that are specifically meant to prevent weight gain. And that includes things such as self-induced vomiting, the abuse of laxatives and diuretics, sometimes skipping meals entirely, and overexercising. The binge eating and compensatory behaviors occur on average at least once a week for 3 months, and this is a change from DSM-4, where these behaviors had to occur on average twice a week. So much like anorexia nervosa, this is an example of loosening up the criteria to obtain a diagnosis of bulimia nervosa. Just like in anorexia nervosa, there is a unduly influence of body shape and weight concerns on patients' self-evaluation, and patients cannot have a diagnosis of both anorexia nervosa and bulimia nervosa if criteria for both illnesses are met. The patient's diagnosis would be anorexia nervosa. Here's some more facts about bulimia nervosa. It is a predominantly female disorder, but the percentage of patients who are female is not as high as it is in anorexia nervosa. Very significantly, patients with bulimia nervosa are not low weight. They're often normal weight or sometimes above normal weight. The typical age of onset is around 18 years old, but patients do not often seek treatment once the illness begins. That may not occur for a few years until a few years later. And the binges themselves are quite large, approximately 2,000 calories. And at one time, it was thought that these binges were predominantly one food group, carbohydrates, but they're actually often consisting of multiple different food groups, proteins, fats, etc. In terms of the type of compensatory behaviors that patients use, the vast majority of patients are vomiting as their compensatory behavior. However, you can see that very often patients are using multiple different behaviors, with about a third of patients abusing laxatives. The physical complications of bulimia nervosa are sometimes not thought to be as severe as those in anorexia nervosa, but they can be quite debilitating. Patients frequently report having disruption of their normal menstrual function. There's frequently an erosion of the dental enamel that would result from vomiting. Patients may develop a dependence on laxatives for their normal GI function. And again, relating to vomiting, patients may develop a swelling of their parotid glands. In terms of laboratory abnormalities that are seen, we often see drops in potassium levels as a result of purging, of vomiting. We often see lowering of chloride and sodium levels as well. And amylase levels can rise when patients are vomiting frequently. This is a picture of a patient with erosion of the dental enamel, which is often evident on the physical exam. This is another picture of a patient who has a swelling of her parotid gland, again resulting from recurrent vomiting. Russell's sign is the scarring or callousing of the hands that occurs when patients use their hands to induce vomiting, scraping the back of the hand. And when we talk about the physical complications of bulimia nervosa, there are often some unintended risks. As you can see, this is a patient who has swallowed a fork. Patients frequently use different objects other than their hands to make themselves vomit, and that can be quite dangerous. The treatment of bulimia nervosa, the goal of treatment is to disrupt the cycle of binge eating and purging. And there are good evidence-based psychotherapies. It includes cognitive behavioral therapy, CBT, and interpersonal therapy, IPT. And in contrast to anorexia nervosa, there are good evidence-based medication treatments. The antidepressant category medication often helps patients reduce the frequency of their binging and purging symptoms. And typically, it's in the higher dosing range that we see the best outcomes. For example, around 60 milligrams of fluoxetine. And generally speaking, the outcomes for bulimia nervosa are quite good. In this slide, we can see a depiction of the effectiveness of fluoxetine for patients who have bulimia nervosa. The light blue line is placebo patients. The dark blue line is patients who are on the active medication fluoxetine. And what's evident isn't just the separation between the two curves showing a reduction in the frequency of binging episodes. It's also notable how quickly those two curves separate. After just 2 weeks, we see a significant reduction as compared to placebo for patients who are taking fluoxetine. And this difference seems to carry on for months. Binge eating disorder, often referred to as BED. I'm going to begin by talking about the DSM-5 criteria for binge eating disorder. It includes recurrent episodes of binge eating, much like in bulimia nervosa. The binge eating episodes themselves are associated with either patients eating much more quickly than they normally eat, patients feeling uncomfortably full after eating and eating until they reach that point, patients eating excessive amounts of food even though they're not hungry, patients doing this while they're alone and doing this alone because of the embarrassment they may feel about how much they're eating, and a feeling of disgust or depression or guilt after these binge episodes. Patients are reporting distress regarding that their binge eating is present, and these binging episodes occur on average at least once a week for 3 months. And in stark contrast to bulimia nervosa, these binge episodes are not accompanied by the use of compensatory behaviors. This slide gives some information about the prevalence of binge eating disorder. In one study that looked at obese patients who were enrolled in weight loss programs, over half of them had symptoms of binge eating. Now, of course, not all patients with binge eating will meet criteria for binge eating disorder. Only 30% did, but that's still a very high number. When you compare that to patients in a general community sample, the frequency of binge eating is, of course, much lower at 6.3%, but still very prevalent in the community. And again, a smaller number would meet criteria for binge eating disorder. Some notable features about binge eating disorder. It is not the same thing as obesity. It is present in a subgroup of obese individuals. And these patients report much higher rates of both mood and anxiety symptoms. There is a very good response to multiple different types of treatment. That would include cognitive behavioral therapy, interpersonal therapy, and both antidepressant and appetite suppressing medications. There is a high placebo response rate as well. And when we're talking about treatment, it's important to differentiate between reduction in binge eating disorder symptoms and weight loss. Weight loss typically only occurs with the use of medications that specifically target weight loss.
Avoidant restrictive food intake disorder, also called ARFID, is one of those lesser known conditions that I mentioned at the start of the course. ARFID is actually a reorganization, a clarification of a diagnosis that used to be in the DSM-4 manual, feeding and eating disorder of infancy and early childhood. In this current version, ARFID describes those individuals who eat very restrictively. They may avoid or restrict the eating of foods to the point that they get into nutritional trouble. They fail to meet their nutritional needs. Now, these are individuals with no shape or weight concerns. They don't have a classic eating disorder as we know anorexia nervosa or bulimia nervosa to exist. This is a condition not explained by a lack of food or cultural practices that may explain the behavior. This may be a condition that develops in the context of somebody who's afraid. Maybe they're afraid of that they may vomit when they eat, or they may be afraid that they may choke when they eat, or they may have a great sensitivity to eating different textures, and they may find that they only can tolerate very small numbers and types of foods. Again, this is a condition that is diagnosed only when specific clinical attention is needed for the condition, and it's a condition that does not take place together with the other classic eating disorders such as anorexia nervosa or bulimia nervosa. There has been some work taking a look at whether ARFID is any different from the other eating disorders in terms of who's affected and who presents for treatment, and in a sample that was collected in an adolescent medicine clinic, a group of pediatricians who see a lot of eating problems in their practice. They noted that a large group of individuals who met criteria for ARFID were somewhat younger than the individuals who presented for anorexia nervosa or bulimia nervosa. They were 12.9, give or take, years old. They were slightly higher in weight than the individuals with anorexia nervosa, but lower in weight than those with bulimia nervosa. They had been ill for a little longer than the other two eating disorder groups before they were brought in for treatment by their families. And the gender balance of the ARFID group was a little bit more balanced. Still more females than males were affected with ARFID in this particular clinical group, but the numbers were a little bit more balanced than what we see typically in anorexia nervosa or bulimia nervosa. PICA, many of you have heard of PICA. It's now sitting within the eating and feeding disorder diagnostic list in DSM-5. That's what's new about this. But PICA is the syndrome of eating non-food substances. It's diagnosed only when the behavior is inappropriate for the developmental level of the affected individual. So this doesn't describe toddlers who put things in their mouths and need to be reminded not to. This is an ongoing pattern of eating non-nutritive substance when it's not appropriate. PICA is not diagnosed when a behavior is culturally sanctioned. Rumination disorder is the repeated regurgitation of food, meaning that food is brought up from the stomach and sits in the mouth, and it can either be re-swallowed or spit out, or there could be even a ritual around the food being brought up again. This is a condition not due to a gastrointestinal disorder, although it may have started following some initial gastrointestinal difficulties, but it becomes its own problem that needs clinical attention. Rumination disorder is not part of another eating disorder in the way that these diagnoses are described. Again, it may have begun in the context of some other eating problem, but at the point where it receives its own diagnosis, it needs its own clinical attention for the rumination problem. Eating disorders have typically been described as presenting in Western cultures and not as commonly in some other settings, but there's no question that in the current age, eating disorders are present in both developed and developing countries, and we see this in increasing numbers of case reports that describe anorexia nervosa and bulimia nervosa and binge eating disorder being present in all parts of the world. There are patterns of food avoidant behaviors without an identifiable medical cause that may really be our indication that an eating disorder is present, and these presentations should be viewed with concern. Eating disorders may present somewhat differently in different cultures. For example, there are parts of the world where individuals present very medical symptoms to any doctor they see. An eating disorder may present with leading symptoms of there's something wrong with my digestion, there's something wrong with my stomach, rather than a leading symptom that has to do with a psychological motivator for the avoidant eating. Eating habits should be viewed with an awareness of the different social contexts in the different parts of the world. That will help us make a most accurate diagnosis when someone presents anywhere they may present. In summary, eating disorders are serious psychiatric illnesses. They've got high rates of morbidity and mortality. There are increasing prevalence rates for eating disorders worldwide. There are different types of eating disorders, and the different types have different types of treatments. And it's important that we make a proper diagnosis so that we set someone on the course toward recovery. Eating disorders may present differently in different cultures, and having some cultural sensitivity is very important to best understanding and best eliciting the symptoms of a possible eating disorder. Thank you.